Hello, everyone. Whilst we're waiting, I think I might as well go through what to expect for this session. You're welcome to the Pandemics and Service Delivery session at the CSAE conference. And for today, we have 3 fantastic presentations. Each presentation will be 15 minutes each. Thereafter, we will have 20 or so minutes for questions. We encourage you to submit your questions as each presenter is speaking. Don't wait till the end. You can use the Q&A function throughout the presentations. And just so that you know, your questions that you submit will only actually be visible to the chair and the panelists. So if you submit and you don't see your question, we have seen your question. And we will call on you if your question is selected for you to ask your question. If you would like to ask your question, you will be unmuted and you will be permitted to ask your question. Also, please note that the session is being recorded. So if you do ask a question, your voice will be on the recording. If you would like not to be on the recording, you can also let us know and your question will be read out for you. All right, I think that is everything that we have to go through. I am very excited for this session because there are very clear policy implications, and I hope each speaker will be highlighting that throughout their presentations. Our very first speaker today is Christopher, and Christopher is coming to us from Australia. So we are super grateful that he's up this late at night and very excited for what you have to share for us. I'm just gonna stop sharing so you can go ahead and share your presentation. Over to you, Christopher.
Great, good to go. Cool. Yeah, thank you for this opportunity to present this paper. Look, we've done this work here on addressing vaccine hesitancy. And when I presented it to the government of Papua New Guinea, they actually came back to me and they said, should it really be about addressing vaccine hesitancy or should it be about addressing vaccine apathy? And I guess that's a question for you to think through as I talk through the results of the study. Now, it's a joint work with Terence Wood and also Ellen Munro, and we kind of have come at this from different perspectives. Ellen more of a public health background, Terence from a political science background, and myself from a micro development economist background. So it's an interdisciplinary piece. And I'm not going to show you any regression tables in the slides, but I'm more than happy to answer any sort of like econometric questions you have in the Q&A. Now, let me sort of start off just by setting the scene by highlighting something which probably for a lot of people on this call, they won't realize that Papua New Guinea actually has one of the lowest rates of COVID-19 vaccination in the world, much lower than the average for sub-Saharan Africa. Only around 3% of the population is vaccinated. And this is despite the fact that it actually having access to more vaccines than the typical low or middle income country in the world, partly through to vaccines being provided from Australia to Papua New Guinea, in addition to the COVAX facility. So there's supply, not really very much of an issue. Demand definitely is. And the challenge then facing policymakers is, can anything be done about this? How elastic is sort of people's willingness to get vaccinated in PNG? And this is what we explored. And in the study, what we show is that people's willingness to get the vaccine is very strongly correlated with whether they trusted that it has important health benefits and what they think other people will do. Whereas other explanations that you hear a lot of the time, such as the fact that people aren't concerned about COVID-19, right? Or people haven't been vaccinated in the past, so that's why they're not interested in being vaccinated in this instance. There was no evidence to suggest that was the case. And we actually show that actually just conveying the fact that COVID-19 vaccines are safe, whereas getting COVID is actually potentially deadly. That simple information can actually lead to large increases in willingness for people to get vaccinated. And we do this through a combination of a phone survey and an online experiment that have very similar results, even though they're using different platforms at different points in times. And despite how we weight the data, we're getting very similar findings. So let me kind of provide a little bit of an overview as to what I'm going to run through. And then, as Jennifer mentioned, there will be an opportunity to sort of talk through some of the implications at the end. In terms of the study design, I guess I just want to start off by highlighting that there's actually been an absence of work done on how to address COVID-19 vaccine hesitancy in low and middle income countries. It's rather striking, actually, just how little work has been done in this space. There's been broadly representative phone surveys, primarily done by the World Bank and a few other international organizations that don't have any sort of causal element to them. And then there's been a much smaller number of randomized survey experiments, right? Primarily actually in high income countries. There's been some work in low and middle income countries in this space. But to the best of our knowledge, there hasn't actually been an attempt to do both of these pieces of work alongside each other to see what we can learn from doing that. So we do that in Papua New Guinea. We have a phone survey where it's more than just using random digit dialing, right? We also use information about the most recent ping, so the most recent tower that you used when you had your phone, to try and better ensure geographic spread and use quotas that way. And we also looked at people's past history of phone use in terms of whether or not they've sent SMSs, because of the fact that a text message can only be sent by someone who's literate, right? So we could use that sort of information to sort of back out kind of an estimate as to whether or not people actually had, were likely to be poorer, right? So instead of just doing random digit dialing, we had these elements that helped us get a more representative survey than a typical phone survey that does random digit dialing. We also did this, so we're collecting the data in real time because of the fact that we conduct the online survey experiment very shortly afterwards, and we inform the online survey experiment from the phone survey. So you'll understand what I mean as I explain what the results are first of the phone survey and then the online experiment. In terms of the online experiment, we used Facebook advertisements to recruit people with quotas based on age, sex, location, asking very similar questions to the actual phone survey. And I'll provide more details later on in terms of what the treatments were that we provided. Now, you don't have to be a rocket scientist, right, to realize that phone and internet coverage is not universal in PNG at all. So in Papua New Guinea, in fact, the majority of the population doesn't have access to a phone, and a much smaller population has access to the internet, right? Which dramatically, I guess, restricts our ability to talk about the general population. So as a result, in the paper, we use several weighting techniques, the most simplest of which is an inverse probability weighting using the census data to try and match based upon whether the people's sex, their age, their location, because of the fact that an online experiment or a phone survey disproportionately had more men, disproportionately had younger people, and also it varied which region they were in. We use more advanced weighting techniques as well, based upon the demographic and health survey. More information about that's in the paper. But I guess the key thing I want to highlight is that we try to ensure that we can learn something about the general population from the work that we do. The thing which I think provides me with the most confidence that the results that we generate are generalizable across PNG, or at least to some extent they are, is that no matter how we weight, even if we don't use any weights, the story that I'm telling you, the findings that I'm showing you, are almost identical, right? So throughout the rest, I'm not actually going to talk about weighting very much at all because it actually made very little difference, right? So it provides us with some confidence that what we're looking at, we should feel relatively sort of reassured that it's not purely driven by some kind of unique sample of the population. But just one final point, because no doubt this will come up in the Q&A. You might think to yourself, internet users, they only make up 10% of the overall population. But in Papua New Guinea, more than half the population is below the age of 18. And in fact, around 1 in 5 adults have a Facebook account. Now, right now, the actual vaccination rate is 3% for the population as a whole. It's been around 3% for almost 6 months, right? So even if we could only learn something about internet users, and even if we could only learn something about adult population who have access to Facebook, that's still a much bigger share of the population than what actually than is currently vaccinated. So that's the setting. Let's get into what the findings are. So in terms of levels of vaccine hesitancy, incredibly high. And whether I show you the results from the phone survey, whether I show the results of the online survey, very similar story, right? Which is most people in Papua New Guinea, when they're asked whether or not they're willing to get vaccinated, answer no. There's a decent chunk that say they're unsure. Very few people say yes. The most common reason is being worried about side effects, right? And also not trusting vaccines. Now, these two findings here are very similar to what has actually been shown in a lot of the other countries that were in. I'll just go back to that slide at the start. Very similar to a lot of the other countries that are marked in a sort of dark orange or lighter orange, right? Whereby a lot of people say they don't want to get vaccinated, and a lot of the main reason why is side effects and also not trusting vaccines, right? So it's a very similar pattern. And as I said, it kind of leaves policymakers with where to from here. You know, if people are worried, are saying that they're worried, how do we reassure this? Is there any ability to change people's minds? And I guess I just want to highlight, first of all, a key descriptive finding that we have, which is when we ask people who could change their minds, 2/3 of people actually listed examples of whether it be a health worker, a family and friend, a religious leader, and those other categories they could pick from as well. Only 1/3 of people said no one could change their mind, right? So that's kind of already promising to actually illustrate that maybe it is actually more about vaccine apathy than it is about vaccine hesitancy, right? Or a true anti-vax sort of sentiment may not actually be what's going on. When we asked people in terms of further questions, we probed in the phone survey to understand this a bit better. What we found was that when people say health workers or medical professionals, what do they mean? They mean face-to-face communication from their local healthcare worker is what they're interested in. So that's an important thing that we'll come back to. What are the drivers of vaccine hesitancy? Well, as I mentioned, there's a lot of discussion about what could potentially be behind this, you know, whether it's a lack of trust in the vaccine, whether it's some social norms, whether it's the fact that just people don't care about getting COVID, right? Or whether it's the fact that they haven't been vaccinated in the past, so well, they get vaccinated now. So these are good explanations, but we kind of want to see what does the data have to say, which ones are actually most likely to be supported by the data. In the interest of time, I'm actually just going to jump through the descriptive findings and get straight to some of the regressions we ran. On this, this chart actually just summarizes pretty much identical to the descriptive findings, just summarizes that once you control for demographic characteristics, if people said they trusted the vaccine, right, they were on average around 70 percentage points more likely to say that they'd get vaccinated, right? If they said they thought that other people in their family and friends would get vaccinated, they are in the order of around 60 percentage points more likely to say that they'll be willing to get vaccinated. If in terms of people's levels of concern about getting COVID or their prior vaccination history, entirely unrelated, right, as to whether or not people are willing to get vaccinated. And here's an example of this here in terms of, say, past history getting vaccinated. This is the share of respondents that were previously vaccinated. If you said that you were planning on getting vaccinated or willing to get vaccinated for COVID-19, around almost 45% of those people had been previously vaccinated, right? People who said that they weren't planning on getting vaccinated for COVID-19. Well, almost 50% of them had previously been vaccinated, right? So these trends that are summarized here in this chart, right, are clear in the descriptive patterns as well. I'm conscious of the time.
Christopher,
so
you have 5 minutes.
Yep. So I'm going to continue to move and through. I'm more than happy to answer any questions that people have on this. But I guess just in summary, I guess one of the key things you'd want to walk away from this, looking at the phone survey results, is that trust in the vaccine seems to be crucial. Social norms or belief about what other people are going to do seems to be crucial, right? And remember when I sort of mentioned here in terms of who could change people's minds, it's medical professionals or health workers. And then when we probe further, it seemed to be the local healthcare workers through face-to-face communication, right? So they're the three sort of key takeaways you would have, and they actually form the basis for the treatments that we provided in the online randomized survey experiment, right? So as I mentioned, we recruit through Facebook. Just to clarify this a little bit further, the advertisement on Facebook reached hundreds of thousands of people in Papua New Guinea. A small fraction of them actually click, and the advertisement was just saying, complete a survey for 5 minutes and you'll get the chance to win, I think it's in the order of like $50 equivalent of phone credit, right? So there was no way saying like, come tell us your views about why you're an anti-vaxxer. Or, it wasn't like, the ad was meant to be very neutral to attract people in who were interested in winning phone credit. Respondents were then randomly allocated into one of 4 groups, and then they were just asked about their intentions to get vaccinated. The first group was referring to what experts sort of would recommend to them. The second group was about social norms, right? At that point in time, 20,000 people in Papua New Guinea had been vaccinated. So kind of highlighting that other people in PNG are getting vaccinated. Would that motivate them? And the third one being sort of relative safety. This story here about the fact that there's been no severe side effects. At that point in time, there had been no severe side effects reported in Papua New Guinea, but yet there'd been hundreds of deaths. Right? And so these were the 3 treatments that were informed by the phone survey that we then sort of test, try and understand. And remember, the main motivation here is to try and understand, is it possible to increase demand for vaccines, right? And that's what we're kind of really interested in, understanding the elasticity here. Or if I can go all the way back to the start, right? The way how I framed it was, is this about vaccine hesitancy or anti-vaxxers, or is it about vaccine apathy, and can you shift people's views quite easily with a small prompt? And what do we find? We find that actually it's very easy to increase people's willingness to get vaccinated with just a simple message, right? The relative safety message had the largest impact, right? Followed by the social norms message. The experts message was was not significant in terms of reducing the share of people who are unwilling to get vaccinated, was only just significant in terms of the share of people who were willing to be vaccinated. So for argument's sake, let's say the social norms and the relative safety treatment seem to have an impact, right? Experts, not so much. Our interpretation from this is that the experts treatment was unlikely to have as much of an impact when we already knew through the phone surveys that people want to get face-to-face communication from the health workers, right? So
Christopher, kindly wrap up in the next minute.
Yep, great. So I guess I've already summarized the results. And I guess I just want to sort of highlight what the sort of key takeaways we see from this study are, right? Which is there's a real need to boost trust, right, in the vaccines to kind of nudge people out of this state of vaccine apathy, right, which it seems that people are in, that local healthcare workers will have a crucial role to play, and that we would expect there to be this situation to move a country like Papua New Guinea out of a low-level equilibrium where not many people are vaccinated as you can get more people to get vaccinated, you would expect more people to get vaccinated, right? So there's kind of this real flow-on effect and multiplier from getting people vaccinated. So really, if there's one key takeaway from this, it is actually maybe part of what's holding back the rates of vaccination, around the world in a lot of settings, such as in PNG, right, is actually more about the fact that people are just a bit apathetic, and it's quite easy to increase willingness to get the vaccine with the right message from the right people, right? It's actually much less a story of there being hardened anti-vax views entrenched in a lot of places. I'll leave it there, and I look forward to taking your questions.
Thank you so much for that presentation. That was really interesting. That it's less about hesitancy, and if it is a case of apathy, that people can move, and as more people get vaccinated, even more will get vaccinated. This is a really key and important message, so thank you for that. Moving from PNG, we're going to Bangladesh. So I'm going to move over to you, Sebastian. Thank you so much.
Yes, thanks for the introduction and thanks for the invitation to present here. So yeah, my name is Sebastian and I'm presenting the paper Information Provision over the Phone Saves Life, a randomized controlled trial to contain COVID-19 in rural Bangladesh at the pandemic's onset. It's joint work with Shemai Chaudhuri, Hannah Schidbeck-Hörisch and Matthias Sutter. And let me jump right to what we did in the study. So we conducted an RCT to evaluate the effectiveness of an information campaign plus monetary treatment. So basically what we did is what Christopher's results suggested, but we did it with respect to containment or measures to contain COVID. So we called participants on the phone, and we did it with more than 3,000 households from 150 villages in 4 rural districts of Bangladesh. And we did that at the very beginning of the pandemic in 2020. We had 3 treatment groups, control group, which consists of a control group in untreated villages, so a pure control group, and also control group in treated villages. Then we have info-only treatment, which basically consists of an information campaign, which summarized the governmental campaign. What we did there was to inform about the 3 most important social distancing and hygiene measures. We also informed about the 3 most common symptoms and 3 measures to take in case the respondent or another household member showed these symptoms. Then we summarized at the end of the call, we summarized those information, sent it in a text message. And we also illustrate the effects of a exponential spread within the village. And we also gave an example to that. So we said, if you infect 10 persons and they in turn infect 10 others, and they in turn infect 10 others, then already your whole village is infected. So you might want to avoid that. In the last treatment, the Info Plus Money treatment, this basically is just the information campaign plus an unconditional cash transfer of 2 to 3 days wage in agricultural sector in that area. And the motivation for that 3rd treatment was basically to signal that it's important, but also to give support for participants or recompensation to stick to social or physical distancing measures, because it's costly in our context, because people cannot go to the street and sell their products and so on. So they forego money by sticking to those physical distancing advices. However, we paid that unconditionally, so there was no enforcement whatsoever. In terms of measurement, we conducted 2 household surveys after our intervention, first 2 weeks after, and the second about 3 months after the intervention, to learn about the effects of our intervention. Okay, now let me give you some background about the contribution and the setting in Bangladesh. First, the contribution. What we've seen on the aggregate level are mass media campaigns to prevent further spread of COVID-19, which were successful. From then, we have learned that it depends on the level of trust in national governments and also on the actual content and reliability of the information, whether or not they work. What is, however, not clear from those studies on their aggregate level as whether or whom those campaigns reach in the first place, whether they are successful in also targeting those that are illiterate and poor and maybe most vulnerable. Also, what about the channels? So is it knowledge? Is it norms? We can't say much about that from a mass media or from a macro level. On the household level, we know that information provision can affect health-related behavior, for example, here in the HIV study by Dupas. But also we know that nudges may not form persistent habits, which has been shown by Brandon. And from the current pandemic, we know that correcting misperceptions about exponential growth may support or may increase the support for social distancing measures. Text messages may increase awareness, reduce travel, increase reporting of symptoms to health workers, and phone calls might improve the willingness to comply with public health guidelines. But we don't really know whether all this intentional behavior really then carries over to health, and whether that expression of adhering to that rules really then leads to improved health. So whether information can induce a quick behavioral change to protect one's health before vaccines can be developed, or even like, for example, now with the newest versions of the virus where the vaccines are not that effective in containing an infection. So whether like quick information provision can make a change. Moreover, we can also inform about spillover effects. I'm going to talk about that in a second. So now coming to the setting and the study design. So here's the graph of the evolution of the pandemic in Bangladesh. Those are weekly reported cases starting here in December 2019, so there were none, and this is December 2021. So what we see is that in Bangladesh, the situation was relatively mild for relatively long. COVID reached Bangladesh relatively late. The first cases were here in March, 8th of March, and then the first deaths 2 weeks later, about here. And up until April or May, the evolution was still linear. Somewhere here in March, there was a general holiday, which is basically a lockdown. And what's also worth noting is that the highest number here in the first 1-2 waves, or in the first year of the pandemic, are about, roughly exceed 20,000 cases on a weekly basis. So that means that numbers are relatively low in Bangladesh compared to, for example, Germany had in the second wave around 20,000 cases on a daily basis with a half as large population. But however, it might also be to the testing regime. Okay, now what did we do? Already here, we started a village survey to learn about the situation in Bangladesh, to learn like whether COVID has reached the villages, about migration. I'll come to that in a second. And then at the end of April, so this is here, cases were still linear, we conducted our intervention. 1 week later, we called households again for a reminder call. And then 2 weeks after the intervention, we started the first household survey. And about 2.5 months after the intervention, we started a second household survey to learn about the longer term effects. Don't want to call it long term, but to see whether, how the effects on health have been. So this is here where the first wave is already declining. With respect to treatment assignment or data collection, we did a two-step treatment assignment. First, we randomly assigned villages into control and treatment villages. We did that using the MinMSE method by Martin Schlatter and me. So basically what it does, it tries to form comparable groups, similar to matching, but on a group level. And we did that using information from our village survey. And the information that was that we learned in the village survey was mobility, so number of people that returned to the village from abroad or bigger cities, restriction and social restrictions and social gatherings, so whether how many people attend Friday prayer, whether there was a big event in the village, and so on, and also with respect to the current situation in the village, so number of people showing COVID-19 symptoms or number of people being diagnosed. So all that is pre-treatment information that we keep balanced across the treatment groups in the village, like the villages. Then comes the second step of treatment assignment. So as I said before, we have pure control villages, but we also, or households, but we also have control households in treated villages. So what we do in treatment villages is we form pairs of neighbors. So here's an illustration. So we conduct or we perform a nearest neighbor matching. So for example, those two here, all those in the same colors are neighbors. So those would be neighbors, those would be neighbors, and those would be neighbors. And then we randomly assign one to the control and one to the treatment group. All right, so before I come to the results, let me say something about what we actually measure or where we look at. We have 3 pre-registered outcome scales. So the first is knowledge and attitudes. I come to the details on what is in those scales a little bit later. This is just what we look at. So knowledge and attitudes, behavior, where we look at preventative measures and also physical distancing measures. Importantly, where we include information from like self-reported information, but also information that neighbors report about the households that we treated. And then we also looked at health, where we include, for example, typical COVID-19 symptoms, and also in the 2.5 months after the intervention, also whether someone in the household deceased. All scales are standardized with respect to the control group, and higher values are always more favorable. All right, so now this is the first result, the knowledge and attitude scale. What we did there in detail, so we asked about knowledge. So we had a list of 12 actions that could help in fighting or making a difference in fighting COVID-19. For example, we asked eating garlic, does it make a difference? Or staying at home, and so on. And then we just counted the number of correct answers. We asked also whether participants believe that they self can make a difference and to which extent that they personally believe that they could make a difference. And this we aggregated, formed a scale, and this is the knowledge and attitude scale, all pre-registered. So what we see here is the treatment effects 2 weeks after the intervention and 2.5 months after the intervention. And 2.5 weeks after the intervention, 2 weeks after the intervention, the treatment effects here expressed in standard deviation of the control group, already controlled, by the way, for the situation in the village before the intervention, so from the village survey. So we see that the treatment effect is half a standard deviation, not really a difference between monetary treatment and info-only treatment. And we see that this kind of fades away after 2.5 months. And the reason for that is that the control group, so this is compared to the control group 2.5 months after. So the reason that here the coefficients go down or the effect goes down in comparison to the control group 2.5 months after the intervention is that just the control group catches up in terms of information. So the takeaway from here is that there is a positive effect 2 weeks after the intervention and gives a heads up, and later on the control group catches up. This carries over to behavior. So what we measure with respect to the behavior scale, we ask about prevention in the week before the interview, so number of days in which they followed certain rules, such as sneezing in the elbow or covering mouth and nose, or also washing hands with soap. Also social distancing in the week before the interview, so number of days in which they maintained a 3 feet distance to other people. Social distancing on the day before the interview, so number of times they leave their home, and also the neighbor interaction, where, as I said before, we include what neighbors report and what households report themselves. And this we then again aggregate to a scale, and this is what we look at here. The treatment effects.
Sebastian, you have 5 minutes.
Yeah, thanks. Treatment effects are about 1 magnitude lower than for knowledge and attitudes, but are still about 1/4 of a standard deviation. You see that the effect is a little bit stronger here with, for the monetary treatment, but it's not statistically significant. And this effect also fades out, but contrary to the knowledge scale where just the control group catches up, here it seems that everybody is adhering a little bit less to the rules. But it's also worth noting here that this was already where the numbers slowed down or went down. So this might actually be not that bad in that situation. Right, looking now at the health scale, what we did there, or how we measured that, was to look at symptoms and also whether someone had 2 symptoms or a high risk symptom. And for the 2.5 months later, we also included whether someone in the household was deceased. What we see is that there are significant treatment effects, and the info treatment is doing a bit better here. I can talk about that later, but in the short version of the presentation, I'll leave it here. And now let's look at the probably most objective outcome, which is the number of deaths, or the death toll in the households that we interviewed. So what we see here is a share of households reporting a deceased household member since the onset of COVID-19. And in contrary to what I've shown before, where I just contrasted the treated households in the treatment villages to the control households in control villages, this here now is are all households in treatment villages versus all households in control villages. So this already includes a spillover effect. What we see is that the share of households reporting a deceased household member in control villages is about 1.6% of all the households. And in treatment villages, it decreases to about half of that, about 0.8. And importantly, this effect is about the same for the treated households and the untreated households in treatment villages. So the spillover effect is about the same size than the main treatment effect. And this difference is significant, and it's also robust to different specifications, randomization, inference, and so on. And with that, I come to the conclusion. So what we find is that both our treatments improve knowledge and create the attitude of being decisive in fighting COVID-19, which then translates into improved behavior and subsequently improved self-reported health. This means that the share of households reporting a deceased household member decreased from 1.6% among households in control villages to 0.8 in the treatment villages, which includes a sizable spillover effect. And the implications from our study, now addressing what you, Jennifer, said at the beginning, that would the info treatment scale to the national level, around 5,500 of the 8,300 deaths in the first year of the pandemic could have been saved, which means that it's a scalable and highly cost-effective solution. It indicates that mass media campaigns might not always reach the most vulnerable populations, such as the poor and illiterate, because the government had already launched their campaign before our study took place, or before we conducted our study. It seems that money does not seem to help here, and that quick and reliable one-to-one information at the onset of a pandemic really can save life, or at whatever time when alternative medical solutions are not yet developed or do not work anymore. All right, and with that, I thank you very much for your attention.
Thank you so much for sharing that, Sebastian. It's really interesting learning about the importance of face-to-face campaigns that we learned from Christopher to one-to-one information campaigns that you're just sharing. And we're gonna go from Bangladesh and we're going to go to Noam in Botswana, who's gonna talk to us about learning using low tech, and hopefully we can tie that all 3 presentations together at the end. But for now, over to you, Noam. Please tell us what's happening in Botswana.
Sure, thank you. And what fascinating presentations. I hope I'll get to ask some questions too in the Q&A. Yeah, I'm shifting gears to education. Let me share my screen here. And just like it's been a historic health shock, it's actually also been a historic education shock. So, oh, now I'm getting advanced sharing options. Okay, there we go. Are you able to see this? Wonderful. So today I'll be presenting a paper and study called Schools Out, Experimental Evidence on Limiting Learning Loss Using Low Tech in a Pandemic. And this is joint with Peter Bergman and Moitepi Macheng. So to dive in, the pandemic has been a historic education shock, as I've just mentioned, in addition to health. At the height of the pandemic, over 1 billion children were out of school. And so this is a map of countrywide school closures or localized, and you can see that pretty much in most countries, schools shut down. And this is just at one point in time. And so the question becomes, how do you reach children and provide an education when school is out? And so we turn to low tech to substitute school. And so what we meant when we described low tech were mobile phones, which are high access and low cost. What you can see in the figure here is while the teal, the kind of bluish teal there is pretty low across the income spectrum. So just 20 to 60% of households have internet. In contrast, in the kind of red color there, if I figure out the exact color, it's 80 to 90% own mobile phones. And so mobile phones are a way to reach people, whereas internet, unfortunately, in many low and middle income countries is you're only reaching a really small subset and selected subset of the population. So that's what we turn to, is mobile phones to reach households when school was out of session. We ran a randomized trial in Botswana with 4,550 households. And you can see here a density distribution across the country, pretty much most regions in the country, actually. So this is Botswana. There's a big desert right in the middle there, so there's not that many people. So this is actually most inhabited parts of the country we reached nationally. What was the intervention? It was very simple. So on the left-hand side, you can see is an SMS message with some content in numeracy, so place value problems. And then on the right-hand side was the second treatment arm, which added a phone call, 20-minute phone call once a week to guide households. Often these were caregivers, parents, or siblings working with their primary school children in grades 3 through 5 to walk through these problems and have a little bit of extra support. We also cross-randomized targeted instruction, which I'll talk about in a second, which actually collected data. And I think you can see this here in the sort of second wave, on the children's levels, and then actually customized instruction based on their levels. So if they knew subtraction, the teacher moved on to multiplication. If they didn't, they stayed on subtraction. So I can get more into that. So a bit of the context before the pandemic. Oh, got maybe a fire alarm here. I think it's fake.
May I have your attention, please?
1 second.
Signal tone, you
Sorry
just
about
heard
that.
indicated a report of an emergency in this building.
Jen, I'm gonna pause for a second just to check if this is real. Maybe we can jump to the QA. Thanks.
No problem. Whilst Noam discovers whether his building has a fire or not, hopefully not, let me just quickly encourage everyone in attendance to keep submitting questions to the Q&A. We will get to questions in about 15 minutes or so. But when Noam switches back on his camera, we will assume that all is well. But until then,
Jen, I think it's real. So I'm actually gonna bow out. I'll message if I can come back in. Thank you.
Please do. All right. Okay, we will be checking in on Noam after this presentation to make sure that he's all right. Sorry about this, obviously unplanned, but hoping Noam is going to exit the building safely. We will just go to Q&A, and let me call on our speakers first. Those in attendance, please keep putting questions into Q&A. Let me ask Christopher as our first speaker if you have a question for Sebastian, now that Noam is currently not available.
Great. Well, first thing to say is just say congratulations. Yeah, Sebastian, that's a fantastic study, incredibly useful. And as you say, new variants, but also say reluctance to get the vaccines. There's going to be a need to really understand the sort of.
Sorry to interrupt you, Christopher. Could you speak a little closer into your mic? I think we're having a little bit of a challenge picking up your sound.
Yeah, yep, sorry about that. You can hear me loud and clear. Okay, great. I was just going to say, yeah, I just started saying thank you very much, Sebastian. Great presentation, great paper, real big contribution there. As you mentioned, whether it be variants, new variants, or whether it be sort of just reluctance to get the vaccine, understanding people's behavior and how to change that in terms of the sort of information monetary, sort of like in other ways, not vaccines, is a really crucial part of the sort of story. One thing that just really struck me was how large the order of magnitude was for the sort of reported deaths in the family. You know, like that's incredibly large treatment effect that you're observing. Like, yeah, I mean, it's almost like one of those things whereby if you don't have a large effect, then everyone would be upset, right? But when you do have such a large effect, wow, that does leave me thinking, could there be measurement error? Like what could potentially be behind that? Do you like, yeah, what are some of your sort of kind of robustness checks that you've done around that? Like, can you verify it with any kind of admin data? Like, yeah, I'm just really keen if you can talk more about that. Sorry, that was quite a long-winded question.
No, all fine. Yeah, thanks for the question. So yeah, of course, the effects are pretty large. Therefore, we were surprised as well, I must say. Also because, I mean, the intervention is relatively mild, right? So we gave information and that's it. So first of all, the death toll is low, right? So it's 1.6% versus 1.8. In terms of numbers, so we had about 3,000 households. In terms of numbers, this is, I think, 38 and 14 roughly. So in total, it's about 50 deaths or so, right? So this is, of course, relatively low. So that means, you know, one death more or less does also make a difference in whether it's 50% or whether it's maybe, you know, 35. Nevertheless, the effects are large and sizable. We see it in all the scales. So this is the first thing that kind of makes hope for us that the results do, that they hold, right? You know, whether it's like really 50% or whether it's 55, 45, this is of course then, this is relatively not based on so high numbers, but we see that there's knowledge which translates to behavior, which then in turn translates to better health, and that the health or that the deaths then is the last consequence. This is more or less consequential. So we can track down actually the mechanisms, which is the first thing, which builds, in our view, trust in our results. The next thing is that we use various specifications, and it's always the same result. It's always significant whether we control for the situation in the village before or not. We do have that information from a pre-intervention survey at the village level. We also have it at the time of the village, which we also include, you know, like mobility and migration. We also all include that. In our in the results, we use randomization inference, we use traditional inference. We always come to the same conclusion. What we have done now, but I can't report on that yet because I haven't looked at it. So the sample is a sample that we work on. We've worked with them before, and we kept working with them. So we went also back and asked at later points in time whether there had been deceased household members, not just in the households that we that had reported a casualty before, but to all the households. And the pattern stays the same even in November in 2020. But I can't, so this is not yet like highly polished. I've just looked at it and the pattern stays the same. So this is an additional level of trust. And what we've now done is to go back to all the households that reported the casualty and ask them again, also ask their neighbors again. Because usually, you know, when a neighbor in the neighboring household, someone deceases, also neighbors notice that. So this we had done to verify also that information and to ask again about the symptoms that the disease showed. But I haven't had the time to look at that. We've just received that the data. And so this is what we were thinking about, how to build further trust in these numbers that are high, yes. But I'm pretty, so what we have up to date, I'm pretty confident. And I don't know when exactly, but I can report you about the results of the phone or the international phone verification.
Great, thank you.
Thanks, Christopher and Sebastian. Sebastian, I'm going to turn the tables and ask if you have a question for Christopher.
So I have a bunch of questions that are all kind of related. Sorry, the first is kind of generic, but nevertheless, since you talked or you considered generalizability to quite a high degree or representativeness. So I was wondering, Papua New Guinea, to how many countries would you say it's comparable, or to which type of country it's comparable? And with that, to which contexts can we, like more generally speaking, maybe translate the findings? What's your opinion on that? That's the first thing, and then the second goes into the same direction. The criticism or the hesitancy to get vaccinated. Is that? Do you have any information? Is that maybe some criticism, or not criticism, but lack of trust towards Western medicine, especially in the rural areas, I think. Do you know about that? So that also, in terms of how we can transfer those findings is something. And then I think I leave that for the first part of the question, and I go back to the next part for now.
Great. Yeah, no, thanks for raising these points. And I guess, I could have done a better job, that's for sure, kind of placing Papua New Guinea, I guess, in the world, I guess that's one way of thinking about it. So Papua New Guinea has the highest rate of extreme poverty in the whole of Asia and the Pacific. It's actually more comparable to a sub-Saharan African country in that sense. It also has similar human development outcomes to what you would actually sort of see in sub-Saharan Africa. So kind of in terms of placing it, actually, that one of the reasons why I showed that map, and I thought that map was so sort of clear, was actually this specific development challenge here in terms of uptake of vaccines is actually quite comparable to more like the case in sub-Saharan Africa and a few other sort of countries like, say, Yemen or Afghanistan or Haiti. And that's actually, these countries share a lot of common characteristics. So I do see a great deal of generalizability in that sense. In terms of the sort of trust in Western medicine, I guess one thing that we did include an option for people to select when we asked them who could change your mind, right? About like traditional healers and other sorts of ways of framing that sort of I guess, Western medicine sort of options, and very few people were selecting that, right? The vast majority of people, so half of people who said that they hadn't been vaccinated and that they don't plan to or are unsure, said that they'll change their mind if their healthcare worker would recommend. And we had sort of follow-up questions to probe that deeper, such as where they would like to get that information at their local health clinic, how they'd like to receive that information in person. These sort of follow-up questions really made us feel that actually there is a great deal of trust probably in the more traditional, I guess, Western medicine sort of outposts that do exist. But, and this is the big sort of kind of kicker, right? So I presented these findings many times to policymakers, and it's come up a few times now where people say, yeah, but the health workers themselves are also reluctant, right? So that's potentially part of the problem here, right? Whereby it's like, well, no, I would get vaccinated if my local healthcare worker or my local health worker recommended it, but they're not getting vaccinated either. So therefore, I'm not going to get it, right? So there is that sort of aspect. So it's probably not so much about Western medicine as such, but probably more about the fact that people at the front lines, they're trusted, but they're not necessarily advocates. They can actually be a stumbling block in some instances.
All right, yeah, cool. Thanks for that. Now the second part of the question, whether you have like, so the kind of treatment effects are relatively large, right? Did you follow up on that and to see what happened, whether they then really took action and got vaccinated?
Yep, great question. So we actually did do follow-ups, right? It's challenging in the context of Papua New Guinea, right, to be able to sort of reach people via phone, right, and via the internet again. And the main reason is because of the fact that people's SIM cards in their phone expire after 6 months, right? So you have to get a new SIM card unless you register it with an official government document, but most people don't have an official government document. So anyway, as a result, it does mean this follow-up process is challenging. So there's high attrition, right, between the follow-up rounds. So I didn't even mention it just because of the fact that I don't think it fully meets the bar as sort of being kind of rigorous enough. But having said that, we do see an increase in sort of self-reported, yes, I have now been vaccinated. In terms of whether or not those people have been vaccinated in real life, that's something which we need to dig deeper into going forward. My prior is that they probably haven't actually followed through, even if they self-reported on the fact that they had. In a lot of instances, that may not be the case. So this is why we need to dig deep a little bit further into this. I guess part of what we were more trying to do, just taking a step back, is to try and understand, right, whether this was complete just hostility, right, to the vaccine in general, or whether it was actually more like people were far more open, right, to it. Is it, or can I frame it kind of more like Novak Djokovic, if I can dare say like this, outright hostility versus, maybe the relative that a lot of people maybe have who are unsure, a bit on the fence, or kind of maybe are a bit more kind of, yeah, whatever, I'm not really prioritizing this, right? Do you know what I mean? So there's kind of like that sort of difference, right? Which we're kind of more getting at. And I think just the fact that we can see such large effects through just simply providing such small amounts of information to people would still serve that bigger purpose, even if we can't actually report on what really did happen.
Yeah, absolutely agree on that. Yeah. Even if it's just like 5 people. I mean, yeah, okay, maybe it should be some more in order to be effective, but it's probably still a relatively low number to make, because it's relatively cheap, such interventions, I guess.
Quick question, actually following up on that, Christopher. Did you find any difference in the type of vaccine affecting the trust in the vaccine?
Yeah, so this is a great question. Actually, it's kind of funny because yeah, I should have covered this off. And every time I presented this and I haven't covered it off, it always is asked, right? It's like a really key question. And the thing which I point to is, well, I mean, the short answer is no. And the thing which I point to is that even among people who said that they would get vaccinated, right? So they hadn't been vaccinated yet, but they were willing to get vaccinated. When we then followed up with how many shots do you need to get to be fully vaccinated, 96% said they have no idea, right? 2% said 1 shot, 2% said 2 shots. And the main 2 vaccines are J&J and the AstraZeneca, right? So, it's like there is 1 shot, there is 2 shots. I mean, like, so it's just an example of how much I think people just don't have that sort of level of necessarily engagement, and I think that more falls into the vaccine apathy sort of perspective. In terms of, we do a follow-up survey, we then ask people more explicitly, right, in terms of, would you get vaccinated if it was Pfizer, et cetera? And there was no sort of like clear pattern whereby people were like, gee, I'm just hanging out to get Pfizer, like that was really not the sort of what was taking place at all. But it's, it's a great question. I should have definitely touched on that during the presentation.
Thanks for that clarification. That is interesting. There's a long way to go there in PNG, it seems. Noam, are you back with us? Is everything okay with your building?
Oops. Hi, everyone. Yeah, it won't let me do video, but yeah, things are okay, actually. It was a false alarm in the end. So sorry about that. It's trying to let me do, yeah, no, it was a false alarm. Sorry about that.
No problem. Do you want to, up to you, but you can pick up where you left off, or you can give us a summary presentation instead of like going through everything all over again. But we do have some time and we would really love to hear your presentation.
Sure. Were you guys in a Q&A or?
Yes, we were.
Okay. I'll do it really brief. That way we can come back to the Q&A. Okay, great. But I'll do super brief. And how much time do we have?
You can have 10 minutes.
Okay. But I'll try to be even briefer. Thank you, everyone. I don't know what happened there. So anyway, some context. We had been delivering a program called Teaching at the Right Level in Botswana. This is a partnership with Young Love, the largest NGO in the country, the Ministry of Education, UNICEF, USAID, Pratham, JPAL, and Brookings. Collected phone numbers right as schools closed. The calls and SMS messages happened with children and the parents and caregivers. Interestingly, over 80% of households were not enrolled in prior programming that were enrolled in this COVID response. So actually word spread, and it was quite a national sample that ended up enrolling and pretty representative. And the study was done rapidly. So it was actually borrowing a bit from sort of the medical philosophy of do it really rapidly and have a bit of a stopping rule if it's working, because it was also a bit of a humanitarian need to get working services to as many people as possible. And then also direct policy implications for government. I'm going to just skip through contributions to the literature here, but there are many in our view, and jump to results. So what we see here is in the average level, you can see that the SMS on its own is not effective, 0.02 standard deviations in the red on the left-hand side. And similarly, not huge effects for place value and fractions. And the confidence intervals where they're overlaid here, they cross 0. In contrast, on phone and SMS, when you do the phone call, you're seeing big effects, 0.12 standard deviations, and these are highly significant. And these also translate to place value and fractions, so learning those competencies. So really big effects here. Then when you look at targeted versus not targeted, what you can see is on average level, similar effects. But then if you look at other competencies like place value and fractions, you can see place value and fractions much more. So it looks like there's some suggestive evidence that targeting it can be beneficial. Great. A couple mechanisms, but I'll also skim through these. So one thing I think we often don't pay attention to the control mean. And what you see here in terms of demand and the control mean on the bottom right in the red there is in terms of people who don't want any of these services, it's very low. So actually over 99% of people essentially want these services. So that's really striking in terms of what people want to receive. And then we don't see huge effects on that extensive margin of whether they want any services, because all of them already want services. But then on the sort of intensive margin of demand, you can see here that those who get the SMS want the SMS more, and those who get the phone and the SMS want the phone and SMS more. And the treatment effects are even larger for the phone and SMS, potentially because it was the most effective. So it's not the kind of case of grass is always greener. You want what you didn't get. You actually want what you got. You kind of liked it, especially if it worked, which is a good sign. What about what happens to the parents? So you might be worried that maybe the parents are now participating and spending time educating their child, and maybe they don't have as much time to, let's say, work or go to work, especially for mothers or what have you. We don't actually find that that's the case. We find that the phone and SMS treatment actually reduces the likelihood of not returning to work slightly. So we don't want to overinterpret this. P-value is low, but 0.09. But it doesn't look like there's a crowd out effect in terms of employment. And so that's reassuring. In fact, it looks like kind of the households who participated felt confident to go back to work because their child progressed. So they weren't so worried about their learning, whereas in other households, maybe they were. So some policy implications, very cost effective. So I talked about some of the effectiveness, but one of the striking features of this type of approach is its cost effectiveness. It's very cheap. You're not providing new hardware. You're meeting people where they are. You're using their phones and just providing really good instruction. So per $100, you're getting 0.89 standard deviation, some of the highest, most cost-effective programming in the literature. Governments often have large ICT budgets, information communications technology, but often they're spent on things like tablets, like computers, which do not seem to work very well because people they arrive in schools and then get stowed away in closets and the like. And so this is a way of thinking about repurposing those line items to, instead of providing hardware, meeting people where they are with hardware they already use and providing really good pedagogy. Parents are often engaged in education systems, but much more passively through report cards and things of that nature. This was direct content engagement, which in low literacy settings has been tried less often, but we actually see you can have a breakthrough even in a low middle literacy setting. And then long-term disruptions, this is really important. So COVID has certainly been historic in nature in its disruption, but other disruptions happen. And this has actually really woken us up to that issue. And schools actually close in other settings, weather shocks, typhoons, teacher strikes, natural disasters, and fragile contexts. It's actually estimated that over 2 billion people live in contexts where there's some disruption of this nature. And so it's actually a big issue that there's very little evidence on because it's usually treated as humanitarian. And so people don't generate evidence. And so it's really important to bring evidence to bear on how to deal with school disruption beyond COVID. And we think this contributes to that. And then this was real-time RCT evidence during the pandemic that actually informed some policy responses and follow-on testing. So we've actually continued to work on trials in 6 countries total, 5 additional countries beyond Botswana. And just to allude to that, so the Botswana study was in really the early part of the pandemic. It was actually some of the first experimental evidence in education in the world. And then following that, we launched trials in Kenya, Nepal, India, Philippines, and Uganda, with the results coming in as we speak, actually. So very excited in the next few weeks, we'll actually have those results and we'll share them very soon. And these are partnerships with the World Bank, with governments, with NGOs, and the like. So this will, to our knowledge, actually, this effort will be some of the largest multi-country, fastest evidence generated in education, and showing whether these kind of approaches can really scale, kind of these education and emergencies approaches. There's an opportunity to inform these. We're testing things like around generalizability and adaptability. We're comparing NGO and government delivery to inform scale. We're also randomizing teachers to see if the intervention affects teacher instruction as well as the student and parent outcomes. We're validating our measurements of phone-based learning assessments. And then we're trying to reconcile an emerging literature. There's now been a bunch of research during COVID since that original Botswana study in other countries, in Kenya, in Sierra Leone, in Italy, around similar approaches. And some studies show effectiveness in Bangladesh as well, and some don't. And so trying to reconcile what really are the active ingredients in making this kind of approach work. Great coalition of partners, couldn't do it without the amazing partners, and I'll wrap it up there.
Thank you so much, Noam, and you're even with more time to spare. Thanks for coming back and still giving us a fantastic presentation, even with that fire scare. We appreciate it. That concludes all 3 of our presentations. I would like to encourage our attendees again, if you have any questions to ask our panelists, our presenters today, please do feel free to put it in the Q&A. But in the meantime, I will allow Noam, you just gave that presentation, so I'll give you a moment to catch your breath. and give Sebastian and Christopher an opportunity to ask you any questions that they have some.
Thanks. Yeah, I start. Great presentation. Amazing work. Also curious what the real like great setup that you still plan and that is still ahead will bring. Maybe you said it at the beginning and I forgot in between. Maybe you didn't mention it too detailed, but what was the content of the SMS and the phone calls? What did you do there? Can you say something more about that, maybe, please?
Yeah, definitely. And there's an interesting, I think actually this is speaking to some of the emerging literature here. So one of the efforts in Sierra Leone, for example, did phone calls, but the content was quite different actually from what we studied in Botswana. So the content is key, unsurprisingly. And in their study, for example, it was a kind of a follow-on to a large-scale radio programming that was, I think, focused on some of the basics, but also went a little bit more advanced. But it was sort of more of a one-size-fits-all content. So our content was a combination of really focused on foundational numeracy. So addition, subtraction, multiplication, division, the competencies that kids are not grasping in these grades, and that other research in education in low and middle income countries have shown is really some of the key gaps. But then it was also very targeted. So every week, the teacher would see, is the child grasping addition? And if they're not, they wouldn't move on, actually. Whereas in, let's say, a more kind of national campaign, you know, if the next session is addition, you move on to addition, right? And so you can really miss the child. And so it was very targeted, actually. And so that's one of the features. And so it speaks to the teaching at the right level literature in that way.
That's amazing. So it was managed then on the local level by the teacher, or how did that work precisely? So they sent every week, they sent like an assignment and then got back the results, or how did that work?
Yeah, so our philosophy around targeting is that we provide a mechanism, but it's not like data flows up and flows down, actually. And in fact, one quote that I love, this is from a practitioner, Rukmini Banerjee, the CEO of Prafem. She says, data often defies gravity. It flows up and it never comes back down. Okay, so this is kind of, these systems are often very clunky, as I'm sure everyone here knows. And so we try to avoid that by making sure that it is very local, as you say. And so we say, please ask the child a question to see what they know. So ask them a, let's say, addition or subtraction question, but then you'll decide, you'll see, can they do 2 + 2? And if they can't, you decide. So it's not so controlled, but there is a structure and a mechanism for them to adapt.
Thanks, Sebastian. Christopher, do you have any questions for Noam?
Yeah, just a quick question. So, I mean, fantastic study. Yeah, great work that obviously took place there. And I think it's the thing which got me really excited was when you mentioned that you're actually doing this in a number of other countries. And I guess I'm just like keen to know a little bit more, right, that you're sort of willing to share, because I think that unfortunately, in the economics profession, there isn't very much incentive to do replication sort of work, but actually that's so important, right? Particularly when you're doing these sort of tailored interventions like you are. I guess I'm just really keen to understand a bit more about sort of what you see, how the piece will come together, what do you hope the big story is going to be, etc. If you're willing to share any more on that.
Yeah, absolutely. I would fully agree with that. I think it's been so 6 RCTs, 18 months, 20,000 children, many partners. It's been a doozy. So I think both in terms of the publication incentives, I agree, they're not always there to do something quite like this. And then also, there's just the sheer amount of work, you know, and the infrastructure. So it's tough to pull off. But I will say, I think it's totally worth it. And so, you know, coming out of this, what we're learning is just extraordinary. And I can hint that we'll release the results soon. It does not look like this will be a story where it worked once and it never worked again. It does look like there is a lot here that is replicating, that is scaling. And so I can get more specific soon as we release the results, but it looks to actually be a largely positive story. with some nuance, as there always is. For example, some contexts are seeing really big treatment effects and other contexts are seeing big, but not as big treatment effects. And we need to understand that difference. Why is it so effective in the Philippines, for example? Maybe it's because the school closures there were the longest in the world. That might be one reason. Or maybe it's because the targeting was done really well. So we still need to unpack a lot of that. But I think that's exactly what these replication studies can help us do, actually. And so my hope would be that if we can showcase how this can connect the dots between kind of a really good study to something that can scale and translate and generalize, and then also get into a lot of the really interesting mechanisms. And so, yeah, we're excited about it. I think we're excited about it on multiple levels, and we hope that it's a wave of the future, that this happens more often, actually. And we think it's possible. I think sometimes folks wonder whether it's possible. We think it is possible. So that would be my overview to that, but I'm happy to share more once the studies are actually out.
Thanks, Noam and Christopher. And Noam, I'm going to give you also the same opportunity. Sebastian and Christopher have been asking each other questions. So if you have any questions for their presentation before you had to jump out, please do go ahead.
Yeah, I do actually. Thank you. So I'll start with Christopher. And thank you both. Also found your presentations fascinating and also so timely. And I think this kind of, I guess, a common theme, right? We all sort of responded quickly and tried to bring real-time and rigorous evidence. It's just a treat to see your presentations. Christopher, I had two questions for you. One is very non-technical, but we just discovered, so I also run an NGO with 140 staff, and everyone thought that we had no hesitancy internally. And we just did a survey and only half our staff are vaccinated so far. In field staff, so our full-time staff, most of them are vaccinated, but field staff like teachers and the like. And so we have a policy that you can't go into the schools unless you're vaccinated. And so our own team has been surprised, actually. And so one question I have for you is, what would you recommend for someone who's in this position and now wants to encourage vaccination for 100 people? Based on your research, I guess that also applies to Sebastian, because this is, I will WhatsApp our team right after your response to try to enact your recommendation. On your paper specifically, you draw this, you drew this distinction between hesitancy and apathy. And I think that's really interesting, actually. And I agree, it's sort of a bright light. It makes it feel a bit more tractable. It seemed to me, if I interpreted it correctly, that you draw that conclusion from the effects, that it's sort of, because it's malleable, you therefore conclude it's apathy rather than hesitancy. Correct me if I'm wrong, if that's sort of how you derive that distinction. But if that's the case, I wonder if you can also do some careful measurement to codify how you would measure the difference, not just as a response to whether it works or not, but as a function of just really careful, thought out tool design.
Great. Yeah, look, so I'm going to do the second one first, because it's actually easier to answer than the first one, right? So on the second one, the way how I've sort of framed it there in terms of hesitancy and apathy, it's actually based upon the descriptive results and also the sort of experimental results. And the sort of example of one of the descriptive stats that is so, I think, profound was when we asked people who could change your mind, and 2/3 of people could select people who could change their mind. Like only 1/3 of people were saying no one could, right? Which is already an indication that there's sort of like an openness, right? And to be honest, like I actually don't really like framing it in terms of hesitancy. I guess I'm more trying to highlight, maybe it's more about sort of like anti-vax views versus vaccine apathy, and just remove entirely from the hesitancy sort of word from the equation. Because if we've got these two sort of things here, the anti-vax, right, we would expect there to be people, when we ask them, would anything change your mind? They'd say no one. And then when we did these experimental treatments, we would expect no treatment effects, right? So that's kind of consistent with that. Whereas with the apathy, it's like, could anyone change your mind? Yeah, I guess. And then it's like, well, can we, when we test this, can it change your mind? is there elasticity to your willingness to get vaccinated? And there is, and quite a sizable amount. So I guess that's kind of the way I was kind of framing it and thinking about it. In terms of your sort of question of how to actually sort of like get your sort of staff vaccinated. Well, so it's actually almost, well, it's after midnight here in Australia. So I'm kind of really going to cop out of this question by highlighting that, like, one of the things you aspire, right, when you do policy relevant work is to get someone to ask you at the end, you know, like, or to feed in, like, what do I actually do with this? Do you know what I mean? But it's like, then when someone asks you that, you're actually just like, gee, like, I don't know, you know, like, I'm a researcher, I'm too far, like, removed from reality. Do you know what I mean? Anyway, so there's kind of just that sort of funny sort of tension there. Look, I honestly do think that, you know, it is worth trying to understand whether people are not vaccinated, right? Because the fact that there's sort of the apathy, right? Like, or whether it is actually just like truly like anti-vax sort of thing, because you would approach it in a very different way. I think the anti-vax would be very hard to address with anything other than a mandate, you know, and or to use like the sort of colloquial words, say in Papua New Guinea, it's like no jab, no job, you know, like there's sort of that sort of really hard line. Whereas if it's sort of apathy, I think it's possible to sort of bring people on that journey to understand the benefits of doing it. And I guess given what your organization's trying to achieve, or sorry, not trying, is achieving, people obviously care about other people, right? Not just themselves. And so I think probably highlighting the sort of positive externalities from being vaccinated, I think would be a good starting point. But anyway, I'll stop speculating.
That's great. Not shabby for midnight. That's great. And so one just final question on that is, so on the measurement piece, are you essentially proposing kind of an index of, you know, are you vaxxed? Would you do it? And then is it sort of like a triple index of how malleable your beliefs are combined with whether you would do it?
Yeah, so I'm keen to go deeper into this path. Unfortunately, some of the work that I have seen done in this space is a little too crude to be useful, to be honest. Like, people are sort of I guess, like the design thinking, you know, like sort of think, oh, well, let's just grab one or two things and we'll shove people into these caricatures of the way how people are. But yeah, I guess we are exploring, trying to go into this a bit more sort of deeper, and an index is one of the routes. If you have other suggestions, I'm all ears. So, yeah.
Thank you. And then for Sebastian, I guess some similar questions, if you have any ideas actually on boosting vaccination willingness based on your research. I'm curious, and I'm sorry if I missed this because I think there were starting to happen things in the alarm. So it's possible I missed some things, but one thing just to say, the effects on death are just totally striking. And I wonder, one, is this public and kind of getting a lot of traction, and two, you know, what your sort of plan is to kind of take this further, retest, scale it, given those quite striking results. I think it's one of the few studies I've seen with like showing effects on actual death, in addition to some of the earlier indicators. And then one thought on the short versus long term. So there does seem to be a striking difference there, right? Big short-term effects and long-term effects less clear. I'm curious your thoughts on that, and then also your thoughts on maybe conveying it in a cumulative sense as opposed to two distinct snapshots, and how you're thinking about the difference there. Like, do these effects accumulate, and so how do you want to think about that? Or is it just, you know, it faded? Yeah, anyway, how are you thinking about the short long term? And then the other one difference that I found really striking was the lack of difference between the information and monetary. I felt like it wasn't brought out, that difference between those treatment arms as much, actually. And I feel like that's a really important difference, and it certainly changes the scalability and cost effectiveness. I think in the end, there was a mention of this, but I'm curious what your takeaways on that. So are you sort of saying info only, let's push that, let's move that forward? And that's sort of what one of the things we've learned is not just that it can work, but that the info only seems to work particularly cost effectively.
All right. I think I start from the end. So with respect to the monetary treatment, what we do know is that what I presented was the pre-registered scale on attitudes and knowledge. If we just look at knowledge, it seems that the effect is higher for the info only compared to the monetary treatment. It's about 2/3. And this actually predicts behavior, and it also predicts health. So this might be one part that could explain it, that it kind of crowds out the attention when we call them, right? So, I mean, it kind of makes sense, right? If I tell you some information, and if I additionally tell you that you get a lot of money, then maybe you're not that attentive anymore. So this is something that we can already say. But we also went back to the households and tried to dig deeper there, asked them what they did with the money. It seems that those in the monetary treatment spread the news kind of across more people. So they told more other people about that, which sometimes also meant that they did not adhere to the social or physical distancing measures. So they understood themselves more like, or that's our interpretation so far as a kind of ambassador, and also matches with their feeling or their attitudes, because they had much more the feeling that they themselves can make a change. So that might be something there. Yeah, other than that, we're looking at the data, trying to figure out what more might be going on there. We cannot fully explain this lower effect with the lower knowledge. It's part of the story, but it's probably not the full story. So that's that. Then, with respect to longer terms, I think you were gone when I said that, but we were going back to households again. This is a sample that we've been working on for several years by now, and we also kept working with them after 2020. So we have also in waves, and so in 2020, at the end of 2020, we also asked all the households again whether there was some household member deceased, and the pattern goes into the same direction. But yeah, this is not like polished and really. This was just like a preliminary analysis that I can tell you there. And then we also go back, I think this year even. We're going to ask the same questions to see. And this kind of connects with the question how long-term or short-term, let's not call it long-term, but like medium-term or a little bit longer than short-term, how that connects. I think it like the picture from the beginning to the end kind of is a straight line, right? So knowledge increases at the time you have to have it, and then it translates to behavior, no matter that it fades out later on when numbers are rising again or sinking again, and everyone kind of knows what to do. But the important thing is at the beginning, when people might not know about the disease or how to protect themselves, if at that time you can provide information that might be a game changer. And then this translates not so much to health anymore, but then to the death rate, which then comes about like 2.5 months later. So this is how how we see that, how the short-term and medium-term effects kind of connect.
Thanks, Sebastian. I hope I'm not cutting you, but we are actually at time. And I would really love for us to round out this wonderful discussion well. So in the last minute, we are already 1 minute of a time. I'm going to take 1 minute of everyone's time and kindly request 30 minutes for each speaker for you to just tell us the one take-home message, advice for the policymaker. We really want to drive this home. Give us 30 seconds of your advice that you would give to the policymaker. And I'm going to start with Christopher, then Sebastian, you jump in, then Noam, you conclude for us. Thank you. Christopher.
The results of this study show that it's actually vaccine hesitancy is maybe less of an issue than people realize. Demand is an issue, right? That you can tackle actually because of the fact that actually vaccine apathy is what's going on. So it's possible to dramatically boost demand And I would just encourage policymakers to be optimistic that it is possible to boost the demand and not just fall into the sort of vaccine hesitancy, anti-vax, there's no hope sort of mentality that you can hear around people getting the COVID-19 vaccine.
I would say our study shows that information provision is important, and that it's important even if there are already mass media campaigns, because we show that they couldn't reach everybody. And it's important to inform people face to face, because that seems to make an additional difference. And it is important to do that early. And this is possible with an information campaign via phone, as we've conducted it, and should probably be done more often. So direct communication, easy communication saves life in our case.
Yeah, and I would say two things. One, we've been awakened, some version of that, to the issue of school disruption during COVID and beyond. So it's something we're paying attention to now in terms of a research agenda and a policy response, and that it's possible to help kids learn. And the final thing I will tease on that is it actually looks like the learning progress through these approaches is as good, if not better, actually, than some interventions tested before the pandemic. So it actually looks like there's something here. Maybe it's the one-on-one instruction through the phone that's really targeted and really effective. That's actually worth thinking about, even for a non-disruption setting.
Fantastic. Thank you so much, everyone, for your time, for your patience. I'd like to also encourage you to check the program out and see what other sessions you'd be interested in attending, as well as the networking on Gather Town, 6 p.m. UK time. Thank you. That is all for today, and we hope to see you back in future sessions.